talk about the lymphatic system right here. Lymphatic system, remember at the end of chapter 21, we discussed that, right? We discussed how in terms of lymphatic system, that it allowed us, and here it is, a great picture right here of how the lymphatic system is basically it kind of just right next to or intercalated with the blood capillaries. So what we get normally is this, and I'm going to use a little bit about chapter 21 as a review here. Right? Keep in mind, you have the capillaries here that's transporting blood to the tissues. Here are the cells that require the nutrients. And what happens is that on the arterial end of a capillary, you have blood pressure, 33 millimeters of blood pressure, ejecting fluid out through tiny gaps found in the endothelium of the capillary. So you have a little bit of very small microscopic holes found between the cells that make up your capillary. So the capillary beds are made out of cells called endothelial cells. Very thin, and it's thin for a purpose. The thinner the layering of the capillary, the easier it is for oxygen to diffuse out. The easier it is for carbon dioxide to diffuse in, so that we can carry nutrients towards the targeted tissue and remove waste from the targeted tissue. But there are tiny gaps, though, found between the thinly walled capillaries. Think of this as a garden hose, and I like using a garden hose analogy, a garden hose with small little openings or holes in it. What happens then? Well, what happens when you open your garden hose up all the way? Well, when you open up the spigot of the garden hose all the way, you have a lot more water flow. And you have so much water flow that it starts to eject a little bit of water out of the holes in your garden hose. Here, the hose is not made out of plastic, but the hose itself is made out of blood vessels and our endothelial connections. So there are little tiny openings between the cells. And what happens? What happens is a little bit of fluid leaks out. Now the holes prevent red blood cells and white blood cells from getting out. They're too big, right? Because they're so big, those tiny openings stop red blood cells, white blood cells, and proteins from getting through. But water can leak out of these tiny openings. Salts can leak out of these tiny openings. So then by the time that the blood has gone from the capillary on one side, on the artery side, or the arterial side, and it goes into the venual side, what happens? Well, that blood then has lost a little bit of water and salt, right, on the arterial end. As it loses a little bit of salt and water, there's also a pressure drop. No longer are you pushing that fluid out the closer we get to the venule. What we're seeing then is on the venual side of the capillary, over here, you're gonna have almost a suctioning effect, where some of the water we pushed out on the arteriolar end, 90% of it comes back in on the venual end. As it comes in on the venual end, well, now we introduce it, right, back into the circulation. So 90% of that fluid we pushed out comes back in almost immediately into the vein. 10% goes into the lymphatic system by way of the lymphatic capillaries. And it's kind of pretty cool and incredibly interesting about why this is, right, occurring. So the more fluid that stays out in the tissues, the more fluid that goes into the lymphatic system. And we're gonna see most of your T cells, B cells, and macrophages, most of your specific lymphocytes will be found as part of our lymphatic system. They're found in the lymph nodes or the lymph organs. Why is this important, right? It's important because what happens when you get a cut, right? We've all gotten a cut in our arm, in our fingers, or scrape, right? Or even like a mosquito bite, right? What happens? Well, when you're having a mosquito bite, or you get a cut, you're causing some kind of trauma on the skin. As you're causing trauma in the skin, if you have an insect bite, the skin surrounding that bite, it puffs up and swells. And some people like me, it puffs up a lot, and there's a lot of edema where you get that bite. Why is that important? Well, when you get that bite and it swells up in that area right here, that means you have more fluid in this area. When you get a bite, you're also taking whatever microbes are found on the skin and you're pushing it deeper. As you're pushing it deeper, you're introducing bacterium into the subcutaneous tissue, right? That's why we get infections from it. As you're pushing all the bacterium that was on the surface of our skin, and then you're pushing it deeper. Now you have a combination of bacterium and swelling, right? What happens then? Well, the swelling causes more fluid to be pushed right into the lymphatic capillaries. As there's more and more fluid, there's more fluid movement into the lymphatic capillaries, which draws bacterium with it. So the more fluid we have moving in, the more bacterium also moves along. What happens then? Then we trap that fluid and the bacterium into the lymphatic capillaries and into the lymphatic system, which is perfect because, like I mentioned just a few seconds ago, right? That's where your lymphocytes are found. So we're introducing the bacterium and viruses from the cut into the lymphatic system where we're going to have the cells that kill them be found. So the more swelling, the more favorable it is to push the fluid and bacterium into the lymphatic system. The more favorable it is then to have our white blood cells attack it in the lymphatic system, right? So there's a reason why we get swelling when we get a cut, when we get any kind of insult to our skin. It's so then we can then hopefully, right, with that swelling, introduce the virus, bacteria, fungi that has now been brought in. We can push the fluid and any microbe into the lymphatic system where we actually have more white blood cells there to do the fighting. Now, that's one of the purposes of the lymphatic system, is to reabsorb. So right here, fluid balance, right? Defense, because we have a lot of white blood cells, the lymphatic system is there for immune defense. This is a weird one, fat absorption, right? What makes it weird is that we don't think about it, right? But in the lymphatic system, when we are absorbing nutrients in our GI tract, carbohydrates, right? Monosaccharides like glucose, galactose, and fructose. Those monosaccharides are absorbed directly into the bloodstream. We receive it by the cells then receive the monosaccharides and move it directly into the blood capillaries found in your GI tract. Same thing with amino acids. Amino acids are also absorbed and then introduced immediately into your circulatory system. Fats are different. Fats doesn't go into the circulatory system immediately. Instead, fats are absorbed in the GI tract and moved into lymphatic vessels that has the name lacteals in it. These are specialized lymphatic capillaries, and it allows us to bring fat that we have ingested, we absorb it and bring it into the lacteals, which then allows us to take it through the lymphatic system, and then we introduce it into the bloodstream later on, right? So fats are kind of different in the way we absorb it compared to the other two types of nutrients. So here's the lymphatic system right here. A couple things I want you to know, right? These are your axillary lymph nodes, anterior cervical nodes, right? Then you have the abdominal nodes. So there's a large cluster right here, right? This is called the cisterna chyli. And what it does is it allows all fluid from your GI tract to drain into the cisterna chyli before being introduced into the thoracic duct. Now, because you're having and you're receiving fluid from the small intestines, you're also, if you're eating, then right, and you're absorbing nutrients, that fluid will also contain fats. The fats that you absorb then will then move through the thoracic duct and then up into the subclavian vein on the left side of your body. So this left subclavian vein is where we introduce all that fluid from the GI tract. How about the rest of the body? Lower limbs, you have lymphatic system that then drains into the lymph nodes. These lymph nodes allows us to filter that lymphatic fluid. The lymph nodes also are where we see the actuals, right? The lymph nodes right here, the clusters here, here, here. These clusters of lymph nodes allows us to filter that fluid that's from our limbs. And then if it has any microbe in it, we have white blood cells in these nodes. And that's what we mean by filtering it, right? We have white blood cells here, and the white blood cells will then attack any microbe that's found in that fluid. But then by the time that fluid drains out, let's say this axillary, by the time it drains out, that fluid then will no longer have microbes in it because all the microbes will be stuck in the lymphatic node, right? Being attacked by the white blood cells found in the lymphatic nodes. So when you hear that the white blood cells are found here, these are anterior cervical nodes. When you were young, didn't your parents, when you have like a sore throat, right? If you're a parent right now, you might do the same thing. They touch the side of your neck, right? As you think you have a sore throat, so they palpate, touch the side of your neck, and they'll say like, your glands are swollen. Usually the parents say your glands are swollen. Obviously, should you have a gland on the lateral aspect of your neck? No, right? You have the thyroid gland, but that's central, right? It's not on the sides, it's not lateral. Well, what they're actually palpating are the anterior cervical nodes. And why are they palpable? Normally, you won't feel it if there's no infection. They're palpable because when you have a sore throat, that fluid increases in amount. Remember, whenever you have any kind of infection, there's swelling occurring there. So if you have a sore throat, there's a lot of swelling occurring in your throat, your pharynx. There's a lot of swelling. That fluid gets pushed into the anterior cervical nodes. That fluid also contains viruses and bacterium. As it gets pushed into the anterior cervical nodes, the anterior cervical nodes contains white blood cells that will start attacking any of the microbes. As it starts attacking the microbes, it causes inflammation in the cervical nodes right here. And now you can feel it, right? And it's a sign that you're actually having an active sore throat right here, because now those anterior cervical nodes are more palpable. If there is no infection, there's no inflammation. If there's no inflammation, the nodes won't be swollen, right? If the nodes aren't swollen, usually it's a sign that you don't have the infection, right? Again, the swollen nodes are a sign. A sign is something you see, something you smell, something you feel, right? So it's a sign that you're having an active infection right here. And it's not a gland that's swollen on the side of your neck. It's actually the nodes that you palpate. A couple other things, right? Now, this we'll talk about the rest. This is better to show on a picture, but I'm going to discuss it in terms of what we're mentioning here about drainage, right? So we talk about drainage on the right and left side, but here you can't really see it well. So I'm going to go back here. So the rest of the next like 5 slides actually kind of goes into it, but it's much easier to discuss it on this picture. What you'll notice is this, right? Notice that you have one main lymphatic duct, right lymphatic duct. The right lymphatic duct drains into your right subclavian. The right lymphatic duct allows us to drain all that excess fluid. Allows us to drain all that excess fluid on the right hemisphere of your face, right side of your face, right hemisphere of our brain. So all of your upper right face neck area The right side, all that excess fluid will drain into the right lymphatic duct. The right arm, the right thorax also drains into the right lymphatic duct. Right? So all that excess fluid here goes through the lymphatic duct and goes into the right lymphatic duct, into the right subclavian, where now we can reintroduce it into your circulatory system. Keep in mind, by the time the fluid reaches your right lymphatic duct, look at all these nodes that the fluid has to gone through, meaning that those nodes will hopefully clear all the viruses and bacterium, trap it, those microbes, and kill it at the nodes. So then the fluid that we introduce into the bloodstream right here will be free of any microbe. This is one of the reasons why you can get an infection anywhere, yet still not introduce it into the bloodstream, right? You get infections all the time, but very rarely do we have sepsis. Why? Is because of the way our lymph nodes are meant to clear the microbe. So the lymphatic flow, lymph is the actual fluid that's going to be carrying excess interstitial fluid and microbes, right? So as that lymph goes into the lymph nodes, any microbe gets trapped in the nodes and gets attacked. By the time that lymph fluid drains out of the node, it should be free of microbe. So then we don't have to worry about introducing a bacterium, a fungi, right? A parasite, right? We don't have to worry about that being introduced into your circulatory system because all these nodes are there to, right, filter it out. Now, one other thing, take a look at each side right here. You see the axillary nodes right here. The axillary nodes allows us to drain the breast tissue, right? Why am I talking about breast tissue here? It's because every now and then you will see an older woman, and what they would do is they wearing almost a naked looking sleeve, right? What we used to do in medicine and in surgery is that when a woman has a breast cancer, right? Now the most common breast cancer is ductal carcinoma in situ, right? DCIS. The most important thing about ductal carcinoma in situ is that it very, very, very rarely moves or metastasizes. A cancerous tumor, no matter how big it gets in a location, usually that's not what causes a person to die. Now, obviously, there are exceptions. If you have it in the brain, because there's very little room in the brain, a benign tumor that doesn't move can cause death because there's very little room in the brain. But in the rest of the body, right, the cancers that kill are the ones that move or metastasizes. Breast cancers are notorious by moving through the lymphatic system, right? Then it works its way through, and then it goes into your circulatory system where it can be pushed everywhere in your body. So what they do normally in the 70s and 80s is when a woman would have really bad or real, a cancer, breast cancer that can metastasize, right? They would then remove the breast by a mastectomy, and they would immediately remove all the axillary lymph nodes. If you remove all the axillary lymph nodes, what happens? Number one, right, cancers can seed in these nodes. So then the cells, the cancerous tumor cells, goes into the nodes, it seeds and multiplies. And then if it leaves the nodes, those cancerous cells can go anywhere. So what we want to do is remove some of these nodes, especially the nodes that has been infiltrated with tumor cells. So what they'll used to do is just remove all of them, assuming that they're all been infiltrated with all metastatic cells. The problem then, if you remove all of this, is simple. What happens to that excess fluid in the arm? The face, head, neck region, right? You're not removing those, that can just go right through. But your arm and your chest region. Well, what happens is some people get lymphedema because that 10% of fluid that gets pushed out that should go into the lymphatic system, now that 10% of fluid gets trapped in the lymphatic system, right? It can't go all the way and be reintroduced is you're removing all these nodes. So people would have incredible swelling of that right arm, right, in the right chest region. By the way, this is the reason why, right, older women will tell you that they've had a mastectomy on one side. They've had their nodes being removed, and they will not let you do a blood pressure blood pressure test on that affected arm. The reason's simple. It can be on either side, right? If it's a left breast, then they will not let you touch the left arm to do a blood pressure testing. Why? When you're doing a blood pressure testing, what are you doing? You're putting the cuff on the upper arm region. Then you're squeezing it and you're increasing the pressure. As you increase the pressure, right, you are going to stop any fluid movement at all. What you're going to do is have that fluid that's in the lymphatic capillaries be pushed outwards, and you'll have massive swelling of that arm that you're testing. Massive swelling. If you've ever seen, people with lymphedema, it's not just a little bit of edema that occurs. It can blow up 2-3 times its normal size. The problem is once you blow it up 2-3 times its normal size, because you pressurize that cuff so much, now you don't have any lymphatic nodes here. So then the arm is blown up and you can't have a good way of removing that excess fluid, right? It takes months and months for the arm to go back to normal shape. And all it takes is one time for them to accidentally, all right, not tell the CNA or the medical assistant to not do that arm. Well, they'll one time. The second time, they know, right? They will be almost violent in telling you, no, not this arm, right? You must do the other arm where you didn't have the mastectomy. What happens if you have a bilateral mastectomy and had some of these nodes removed? And that does happen. People have bilateral mastectomies and they've had lymph nodes removed on each side. So how do we do blood pressure testing then? Right? Because they won't let you touch each of the arm, right? Because it will swell up too much. Well, how we do it then is on the femoral, right? But what happens if you're sitting down? If you're sitting down, your femoral artery is lower than your heart. Because it's lower than the heart, you are going to have a falsely high blood pressure every time. So we can't have that patient sitting down then. What you do is you lay them on their back. When you lay somebody flat on their back, the heart and the legs are at the same level. And now you have a correct, right, blood pressure you can check, right? That is how we measure blood pressure in women that have had double mastectomies with nodes that have been removed. Now, in the old days, we remove all the nodes, right? Since the 1980s, right, we do what's called a sentinel node biopsy. We put a little bit of dye into the tissue, right? We find the lymphatic capillary, put a little dye in there, and then watch it move. And then as it moves into the nodes, we take the node, remove that first couple nodes, send it to pathology. As we send it to pathology, if it's been infiltrated with cells, we remove those nodes. Then we look at the other nodes, right? So then we can pinpoint which node has been infiltrated with tumor cells. Remove only those nodes that have been infiltrated with tumor cells, leaving the other ones that are healthy present. So then we'll have at least some flow of lymph fluid back into circulation. Now, whoops, a couple other things. Oops. A couple other things here in terms of our lymphatic system, right? Look at how close, how interdigitated, right? How they're almost overlapping. The lymphatic capillaries are with the blood capillaries. Again, on the arterial side, you have fluid movement out, right? What we call filtering on the arterial side. On the venual side of the capillary, you'll have fluid moving in, otherwise known as reabsorption. So 90% of what we pushed out and filtered, 90% moves right back into the venual. 10% stays within the tissue, right? As it stays within the tissue, it gets pushed into the lymphatic capillaries and then back eventually into lymphatic nodes to be filtered. right? Now we're gonna see is lymphatic system starts with a closed end tube, almost like a test tube. Fluid goes in, and then it moves towards the nodes, right? Now, lymphatic vessels are going to really resemble veins. The veins in the, right? So very small veins, lymphatic capillaries, they look very similar. And what we're going to see is, right, like veins, lymphatic capillaries use the same method for moving blood in a low pressure system against gravity. So we're going to see veins. In veins, we're going to see that we have valves, right? That prevents backflow of blood back down. In the capillaries that are lymphatic, we'll also have valves. In veins, we have the skeletal muscle pump and the respiratory pump to move blood back to the heart. In lymphatic capillaries, same thing. We're gonna have the respiratory and the skeletal muscle pump as well to move, right, lymphatic fluid back in. Now, the right lymphatic duct drains right side of the head, right upper limb, right thorax. The rest of the body, all right, both your legs are going to drain through the thoracic duct right here, right? So your both legs goes through the thoracic duct and goes to the left subclavian. The rest of the GI tract goes to the thoracic duct into the left subclavian. The left side of your head and face goes through into the left subclavian and the left arm and thorax. Now, some of you might have heard of Yersinia pestis or Black Plague, right? In Black Plague, what happens is caused by, right, by bacterium carried on little mites and ticks. What happens is the mites then and fleas, right, gets infected, they bite us and then infect us. As you get the bite, the bacterium is introduced in our bloodstream, right? Then it goes into our lymphatic system. As it goes into our lymphatic system, it gets trapped at the nodes, right? As it gets trapped in the nodes, that bacterium is so strong that our white blood cells have a hard time killing it. In actuality, right, it's so strong that sometimes the white blood cells die off. And then we have a little bit of a necrosis happening here, right? You have an infection in the nodes now. And you have what are called buboes that happen. Now, in Black Plague, the armpit area, axillary nodes, the inguinal area, they start in those areas, right? It's one of the telltale signs that somebody has Black Plague, because at that area in the armpit, it starts to swell up and it turns black. I know it sounds gross, right? In the groin area, it swells up and grows black. And we call those, like swelling and the blackness, we call it buboes. That's how we get the name, bubonic plague, right? Nowadays, it's actually easy to treat. Just a simple round of penicillin is enough to kill, right, the bacterium that causes bubonic plague. The problem is the areas that we do see, right, outbreaks of bubonic plague are actually the areas where you don't have a very good healthcare system, where it's hard to get penicillin, in other words. But penicillin is enough to kill it. And we call it bubonic plague because these lymph nodes, whether it's in the inguinal region, near the groin, or in the armpit region, sometimes in the neck even, right? You see these massive, dark, sometimes even pus-filled, right, swellings that we call buboes. I know, right? Right. So we view that. Now, in terms of the lymphatic system, it's much easier to discuss how these openings work. And what happens is this. Again, there's a reason why things normally happen in our body. So imagine this is on your finger and you get a cut on your finger. As you get a cut on your finger, well, even if we're using something that's been completely clean, like a brand new scalpel, right? What happens when you're undergoing surgery? If you're using a brand new scalpel, we're doing all these techniques to prevent infections, people still get infections, though, right? Why? Is it from the scalpel? Is it from the room? No, it's actually from our own skin. When we're cutting our skin, even with a sharp scalpel, we're pushing a little bit of our epidermis deep into the dermis, deep into the subcutaneous tissue. Anything that's under skin also gets pushed into those regions. So no matter how we try to clean it, we clean it with, right, alcohol, right? We clean it with, right, some kind of antiseptic on our skin. No matter how well you try to clean it, there will always be bacterium, sometimes fungi, God forbid, sometimes parasites on our skin. And you're pushing it inwards as we're making that incision. So the actual act of causing the incision is what also causes the infection that might occur later on. So now, right, as we're pushing that skin deeper into the subcutaneous tissue, you're going to introduce bacterium into the dermis and subcutaneous tissue, right? What happens? You're going to start to swell. That inflammation, that swelling, does two things. One, it stops the bacterium from moving everywhere else into the blood capillaries. Second thing is this, now you have more fluid out here in the subcutaneous tissue, in the interstitial tissue, right? And what happens? The more fluid out here, the more the fluid gets funneled into lymphatic capillaries. As the fluid gets funneled into lymphatic capillaries, the two ends of the cells, right? Well, if you take a look where the, right, you have anchoring material here, and it anchors, so then this area doesn't move. But the ends are not anchored in place. So as there's more fluid coming in, these two ends get pushed inwards and pinched. The more fluid, the more it gets pinched. The more fluid flows into lymphatic capillaries. Perfect. As there's more fluid that flows into lymphatic capillaries, you'll also have more bacterium that gets pushed into the lymphatic capillaries as well. And it moves with the fluid. The more edema, the more fluid, the more microbes gets pushed in as well. Perfect. With these anchoring filaments that maintain the structure, so then there's one-way movement of that fluid, right? So then as you have fluid moving in here, the last one we want is for that fluid fill with bacterium. We don't want that fluid to leak out. So what happens, right? As that fluid moves in, it creates pressure on the sides, right? As it creates pressure on the sides, it closes up any gaps as the fluid goes through. So then there's only one-way flow right here. Perfect, right? Again, whenever there's a fluid that moves through a tube, it creates pressure on the walls of the tube. I know it's hard to imagine. This is how I want you to imagine this. And this is true for our blood vessels. Imagine you have our garden hose. What happens when there's no water in the garden hose? The garden hose collapses, right? What happens if you put a little bit of water through and open the spigot, just a little bit? The garden hose, because there's a little bit of water going through it, creates pressure on the sides of the walls, right? So then if there's only a little bit of water that flows through, you can still squeeze the garden hose, right? But what happens when you put in and you open up the spigot completely and all that fluid is flowing through under a lot of pressure, right? Well, it creates pressure on the walls of the garden hose, like what we see in the capillary. As that happens, right, the garden hose completely distends. It's hard to push down on it because there's so much force that's keeping that hose open from the inside. That's what's happening here. You have so much fluid running in, you have so much force on the walls that the fluid is pushed through and not out. Right, so review the thoracic duct and lymphatic duct, right? Again, here, lymph is referring to the lymphatic vessel, lymphatic fluid. Lymph flows as a result of the milking action of skeletal muscle contraction and respiratory movement. Very similar to a vein, right? Same kind of movement principles as well in a vein, where you need the skeletal muscles to move and contract, where you need the respiratory system to allow movement of that fluid. Again, right, keep in mind, there is no heart attached to the lymphatic system. So fluid is only moved through the skeletal muscle movement and the respiratory pump and gravity, right? So you have the fluid that's being moved, goes through lymphatic vessels, and then through the lymphatic duct. Now what they skipped here are they show the lymph nodes over here, right? But eventually on the right side of the body, goes into the right lymphatic duct. On the left side, the thoracic duct. Right. Now, what about the rest? So we have lymphatic capillaries that are found next to our blood capillaries. Lymphatic capillaries then drain into lymphatic vessels, which then drain into lymph nodes. The lymph nodes then filter that lymph, so then there's no bacterium, no viruses, hopefully no fungi, right? So then the fluid that exits the capillaries will be hopefully pretty sterile. So then we can reintroduce that fluid. Because at this point, we've already filtered it. It should be very similar to plasma. So all we have to do is reintroduce it into the capillary, into your subclavian vein, and it'll be reincorporated pretty easily because it's just like plasma, right? So that's a lymphatic system in terms of lymphatic capillaries and movement of fluid. Now we have lymphatic organs, the main purpose of which is to either seed or allow for the maturation of certain leukocytes or lymphocytes, right? So lymph and lymphocytes, there's a reason why we call T cells and B cells lymphocytes, because most of those lymphocytes are found in the lymph and lymphatic tissues. You don't see a lot of it in our bloodstream, right? Normal, right? Keep in mind, when we do a CBC, and then we remove, right, and we're only checking the formed elements, 99% of the cells are going to be red blood cells. Only 1% is going to be white blood cells, right? So we have very little white blood cells floating around our blood at any one time. Most of the white blood cells, therefore, are found in the lymphatic system. They're found in your lymphatic nodules. They're found in your thymus. They're found in your spleen, right? They're found in your lymph nodes. That's where we see most of the lymphocytes, right? So lymphatic lymphocytes, we're gonna see that our body has different clusters of these. Usually, right, they form little nodules, little small circular areas here that contains, right? And it does look like this. It looks like there's a little bit more purple on the outside, a little bit more, right, almost clear looking on the inside. There's a reason why we have this arrangement, right? Lymphatic nodules, dense aggregations of white blood cells, numerous in the loose connective tissue of the digestive and respiratory system. We also see it in the urinary and reproductive system. What do these all have in common? They have some kind of direct and indirect opening to the environment. So the digestive system, in your throat, in your mouth, right? That's direct connection to the environment. As we're eating, the food that we eat might have microbes in it, right? I know it's kind of, nobody wants to think about it, but we know that, right, in terms of certain kind of bacterium or viruses, we sometimes get infected with it by eating things that we shouldn't. Or, God forbid, right, it's 4th of July coming up, which is crazy. It doesn't even feel like it, does it? Right? So with 4th of July coming up, sometimes you're gonna go to a picnic and eat a potato salad that hasn't been in a cold environment. So I usually tell all my friends and family never to eat potato salad that's been out. The reason why is, right, there's a chance it doesn't have bacterium, but it has some of the toxins, right? And what occurs then is you're eating some of the toxins and it gives you, right, like the 12-hour so-called flu, right? It's not really 12 hours and it's not really the flu, but you do have some kind of ingestion of a toxin that causes you to have diarrhea, vomiting, nausea, right? All as a result of eating that toxin. And what happens is Our cells in the mouth, in the throat, contains clusters of these nodules that for the most part does a good job to prevent bacterium from getting in, but not their toxin. Right, so some of these you guys have heard of, tonsils, right? The tonsils, we're gonna have two palatine tonsils. They're found on the lateral side, on the lateral aspect of our mouth. We have one pharyngeal tonsil, also known as the adenoids, right? That's found in the back of our throat. And then, whoops, you're gonna have one that is right under your tongue called the lingual tonsils. So you have these tonsils that contains lots of white blood cell clusters, and their main purpose is to prevent seeding and infection. Now there are some people, and if you watch on YouTube, it's pretty damn gross. So I'm just gonna give you a little warning, right? That sometimes they see little stones found on the palatine tonsils. And you see what looks like little white rocks on here. Well, those are the bacterium that have already seeded on the tonsil. Gross. You can imagine just how nasty the breath would be, right? If you have just bacterium in large enough quantities that it actually forms a little crystal, much less a large rock here, right? So in the old days, they would just remove the tonsils because it's already been embedded with bacterium. Nowadays, we're a little bit more hesitant in removing the tonsils. But sometimes, if you keep getting recurrent infections, right, sore throat, pharyngitis, then they will remove the tonsils, right? But that is why, if you watch YouTube videos, they kind of see the white, crusty material. Those are bacterium right there. And they've been embedded and seeded with bacterium. Now, in terms of the lymph nodes, superficial near the skin and cord, and we have some superficial ones near the skin and deeper ones, right? Now, in terms of lymph nodes, I want you to know only the physiology, which is these are the structures that filter lymph in a site of what we call antigen presentation, from macrophage to T and B cells, our lymphocytes. It should not make sense right now, but antigen presentation is this. Your T and B cells have specific receptors, proteins on them. Those receptors on T cells are called T cell receptors, and they have a certain shape to it. Because keep in mind, when we talk about recognition, right, we have one microscopic cell that has to recognize a microscopic microbe. How does it recognize that microbe, right? Because it's microscopic, meaning that it doesn't have ears, the cell doesn't have eyes, it doesn't have a nose, it doesn't have anything that we associate with any kind of, right, sense. So how do you communicate that? How do you recognize it? Well, we recognize a cell to another cell by the receptor. The receptor that a T cell has a particular shape. If you have a bacterium, the bacterium has lots of proteins sticking out of its cell wall. Some of those proteins, right, has a certain shape. If the shape of the protein found on the microbe, found on the bacterium, matches the shape of the T cell receptor region, then they can combine. Now you have a physical interaction between this T cell receptor with a particular shape and the bacterium with a protein on its outside surface that has a matching shape. Perfect. That means that T cell can recognize, right, the protein on the bacterium. The T cell can then hopefully kill off the bacterium because it now will get activated by the bacterium. Now the weird thing is this, right? With T and B cells, they have particular shapes on the receptors, and that shape is found, and it should match one or two proteins, and that's it. Now, we used to think that there's something called lock and key, right? So you have a lock. So if you buy, a lock from Home Depot, if you buy a lock from Ace Hardware, right? If you buy it from the same manufacturer, right, you got Schlage, all right, lock. What happens is, if you look at the key for all of them, it looks very similar. Not identical though, but it looks similar. So if you get a key that matches a lock, all the grooves match. So then your key then is able then to open your lock. Perfect. But if you have a key that looks similar, it might even go into the lock, but it doesn't completely match. What happens? Well, because it doesn't completely match, you can't move that lock. You can't open up that door, right? Because there's not a complete match. That's the same thing that we see here, right? In T cells, we have a receptor that specifically has a certain shape, and it can only bind to something that matches that shape perfectly. If we have a microbe that has a protein that matches the shape of the receptor, otherwise known as a key, what happens? That shape that's found on the surface of the microbe, right? It matches completely the T cell receptor. Now we can activate the T cell. Now, what we're going to see is, right, for the most part, T and B cells, they already have all these receptors. So if you have a baby that's 5-6 months old, right, they have within the baby all the T and B cells that they've inherited, right, from you. And those T and B cells are also going to have, each T and B cell going to have a certain receptor that matches a certain shape. So for every single microbe that the baby will encounter, we will find that there's matching T and B cells. Even with the coronavirus, we're going to know, even though nobody's ever seen this coronavirus, right? We've never been exposed to it. Your parents and my parents have never been exposed to it. So there's no immune memory of this coronavirus, right? But yet people survive, right? Yet 95% of people infected survive. Yet 40 to 50% don't even have symptoms. Well, what happens, right? How are we able to survive this infection if we don't supposedly have the cells? The thing is, we have the cells, right? The cells are already present that recognizes that virus. The problem is finding the correct cells in time for you to ward off the virus before you get really ill, right? It's like finding the correct needle in a stack of needles. It's gonna be really hard, right? You want that one needle, but you have thousands and thousands of needles in that stack. How are you gonna find that one needle? It's gonna be really hard. That's what we're seeing here with coronavirus. Even though we have never been exposed to it, we have T cells and B cells. We have billions of these cells already in our immune system, right? Well, we're gonna have T and B cells that recognizes this virus already. The problem is, in some people, by the time we find the right cells, it would be too late. In some people, by the time they find the right cells, they're able to fight out the infection, didn't even know they've been infected, right? It's almost all the luck of the draw, which is crazy to think about, right? Now, older people, they die more commonly from this infection. Why? Because their immune system, their immune hormones are not as strong, right? Their ability to match isn't quite as quick as a younger person would be. So then they're not able, I mean, eventually, if we could stabilize them for a long enough period of time, even elderly people should find the correct cells that recognizes coronavirus. But it takes much longer for them to find the cells. And by that time, they have weakened and weakened and weakened, and the virus has spread over the course of their body. All right, so just keep that in mind. Now, another thing about antigen presentation. When we're first encountering the virus and the bacterium itself, they have protein sticking out of it, right? Bacterium have a cell wall made out of peptidoglycan, right? So if you guys are taking micro, we're gonna talk about it a little bit, right? Out of the cell wall, they have protein sticking out. So for a bacterium, you might have thousands of different proteins sticking out. The bacterium is called an antigen. The protein sticking out is what the actual T and B cells recognize. So a T and B cell, microscopic, right? They're very small. And now we're looking at a T cell receptor, a very small receptor on a very, very small cell. Why am I mentioning it, right? How is that T cell receptor that is so small going to meet up with a bacterium that's much bigger, right? It's too hard. So what we do is have an intermediate. We have this cell, macrophage. The macrophage is going to swallow up. It's a big cell. So when it encounters a virus or a bacterium, it swallows it up, kills it, and all the different proteins from the bacterium, all of them, right, are then placed on the macrophage's receptor. And now the receptor in the macrophage is going to have the bacterium's protein sticking out of it. As it sticks out of it, we say it's presenting the bacterium to the T and B cells. T and B cells cannot recognize a bacterium by itself. T and B cells cannot recognize a virus. Even if it's right next to the virus, it cannot recognize a virus by itself. It needs help. It needs to be presented in a way so then the virus protein or bacterial protein can be manufactured and then, right, can be presented so then it can bind with the receptor, right? So the weird thing is kind of understanding this, right? It's like you have this microbe, it's got the protein already sticking out of it, but because of how big and how many of the actual proteins are sticking out of bacterium, the T and B cells, they have receptors that should recognize it, but it can't unless it's presented a certain way. And the way it's presented is a second cell called a macrophage, swallows up the bacterium, kills it, and then places those proteins on the macrophage's own receptor. Once a protein is placed on the macrophage receptor, then the T and B cells can go around and see if it matches, right? It can only recognize that protein. Now, later on, I'm going to give a specific name for that protein. It can only recognize that protein if it's presented through another receptor. Once it's presented through another receptor, the T cell receptor, the B cell receptor, then goes around to see if there's a physical match. If there's a physical match, perfect. We activate that T cell. Because that T cell, that B cell that we activate now understands that it matches what's invading us, right? Do we want T and B cells that don't recognize what's invading us? No, we don't want to activate those. It'll take up too much space, too much time, right? And it's ineffective. So we only want cells that recognizes the virus and the microbe. Only those cells that recognizes it will be activated. And to make sure we only activate those cells, we have antigen presentation by the macrophages, right? That happens in the lymph nodes. What else? Metastasis through lymph nodes and lymphatic system is characteristic of malignant tumors. So malignant tumor is any tumor that can move around and metastasize. Once it metastasizes, usually it doesn't matter how big a tumor gets as long as it's not in the brain, right? As long as it's not in the brain or on a blood vessel, it doesn't matter how big a tumor gets. And you've seen videos and probably TV shows about people with a 100-pound tumor. And they're still, I mean, they don't look good, but they're still able to live. Why? It's because as long as that tumor stays in one location, it usually doesn't cause a person to die. Once the tumor spreads or metastasizes, that's when the risk of death is going to increase exponentially, right? So once you see metastasis, that means the cancer is spread everywhere. And that's when the risk of death increases tremendously. Now, cancer cells can travel via the blood or lymphatic system. And when it travels, those cells will establish new tumors wherever they move. How can we tell a primary tumor where that first cancer started versus secondary? Well, if you have a secondary tumor, they're usually smaller and there are more of them, right? So let's say you have colon cancer, and the colon cancer then spreads to the liver. Well, it spreads to the liver because of movement through the blood, right? Remember, it goes from, right, in terms of blood flow, it goes from the superior and inferior mesenteric arteries, then goes through the superior mesenteric veins. The superior and inferior mesenteric veins fuses with the splenic vein to form the hepatic portal vein. So any circulation from the GI tract moves through the hepatic portal vein, and the liver receives that blood first. So if you have colon cancer, because of the way that blood moves back to the liver is usually the second organ that receives that tumor, the cancer. And once it moves, it's going to spread throughout your liver next, and it's a sign of metastasis. Secondary tumor sites can be predicted either by direction of lymphatic blood flow or by direction of blood flow, right? Cancerous lymph nodes are firm, enlarged, non-tender. Infected nodes are very tender. That's a big one. So how can we tell if you have a lymph node that you can palpate? Right? Normally you can't palpate it. It's small. It's too small, right? But now you have one that's big. How can we tell if it's caused by an infection or caused by metastatic cancer? Two completely different situations. How we can tell is this: tenderness, right? When you're having an infection, you're having lots and lots of microbes in your lymph node. Your white blood cells are trying to kill it, so they're releasing lots and lots of very strong enzymes, and it's causing a lot of inflammation in your node. When you touch it, it hurts. It's very tender, right? The other, when you have a cancerous node, it's just cells. It's, in a cancer, it's your own body cells that's just now mutated. So then your white blood cells don't really kill it. So there's no immune reaction in the lymph nodes. What happens then? The tumor, that cancerous cell, goes in your nodes and spreads in the node. As it spreads in the node, it can even get super big in there, right? And since there's no immune response, your white blood cells aren't there to kill it, then there's no tenderness as well. So if you have a node that is large and non-tender, we're worried that it could be cancerous. All right, the spleen. With the spleen, remember we kind of discussed, right? The spleen's purpose is to destroy red blood cells, recycle it. It's also there to fight off any foreign substance, any microbe that gets through the lymphatic system, right? So then, even if some of the viruses and bacteria gets into your lymphatic system and goes into your circulatory system, it gets through lymphatic system and into your circulatory system, we at least have one more organ to help make sure that you don't have sepsis. And that organ is the spleen. We're going to see that there's a lot of white blood cells found in the spleen. Tons of them right here in an area we call the white cord, right? And what we're going to do is fight them off, hopefully destroy the microbes away, so then we can reintroduce nice, healthy blood free of any microbe back into your circulation. Right now, you don't need to, for the exam, I'm not going to have differences between white and red pulp on there, right? So just keep that in mind. For the lab practical, very little is actually on the lymphatic system. For lab practical, the next one is going to be just like what we see here. Oops. Right? Right here, right? The name of the nodes: inguinal, the cisterna-chyli, the right lymphatic duct, the thoracic duct, right? The axillary nodes, anterior cervical nodes, spleen, and thymus. That's it. There's like 8 to 9 words for the lymphatic system on our word list for, right, for the next exam, like lab practical. Let me just go through the rest of this material. And it will actually, why don't we take a break now, right? Because when we come back, we're going to talk about immunity. And immunity is pretty difficult. So just a little warning, okay? So let's take a quick 10-minute break, come back, and we'll talk about immune, memory, and immunity in general, okay?